we're going to start with the morphology of one lesion, which is an infantile hemangioma, and I will show variations of those images and how it changes the radiological diagnosis, right? So grossly, we'll just divide them into T2 bright and T2 hypointense lesions, and we'll move from there. Okay, so I'll just, okay, so now is my pointer visible? Yeah. Okay, so this is a 4-week-old child with a right orbital swelling. We can see here these are T2 weighted images because the fluid is bright, and you have a lesion here in the extracorneal space which is really bright on T2. It's got homogeneous enhancement on the post contrast study. Now the two images which are there below are really pixelated. So I want you to familiarize yourself with saying diffusion weighted imaging. So this is a diffusion weighted image where it is slightly bright and slightly dark on the ADC map. ADC map is something that comes along with the diffusion weighted image, and you can put a little region of interest on the lesion and will give you a value. So this one was like 1.4 into 10 power minus 3. You don't have to care about the units. So these are findings which are very typical of an hemangioma. Some people will call it an infantile hemangioma, some people call it a capillary hemangioma, but it is essentially a hemangioma vascular tumor. So ADVC values in hemangiomas are slightly higher. So things generally that are above 1 are more towards the benign side. 1.4 is a very good benign value. Things that go below 1 start moving towards malignant. Things that are 0.6, 0.7 are almost always malignant. This is a 38-year-old lady with an intracorneal lesion. Again, a T2 bright lesion. They're fine. I'm not sure if you can appreciate it, but fine septations inside it, which kind of resemble the pathology specimen. This lesion has good margins. Now, when we see a lesion like this, we do a dynamic contrast enhancement. Why do we do that? Because we want to see this finding of a focus of enhancement in the starting phase, which fills the whole tumor by the time you finish imaging it. And this is pathognomonic of a cavernous hemangioma, which according to the current ISWA classification is a venous malformation. So these are cavernous hemangiomas. The previous one was just a hemangioma. This finding of a point enhancement extending to the whole lesion is what we are looking for. So this is your radiologist, or you should advise your radiologist if you have a clinical suspicion of a cavernous hemangioma to do a dynamic contrast. This is another lesion which looks similar, but look at the enhancement pattern. In the early phase, it had a broad area of enhancement, very unlike a hemangioma, and this was a schwannoma. So dynamic contrast enhancement, very important for cavernous hemangiomas. Now, this is a 14-year-old child with another intracorneal lesion, looks again very similar. But what is different here is that although they are little septation-like areas, some vascularity within the lesion, the dynamic contrast looks like this. There is no nodule of enhancement, no spread. It's just a peripheral enhancement and central enhancement with little non-enhancing areas. So it's not really changed, it's not really filled in. And this lesion was also showing some restriction on diffusion. The ADC value here was less than 1, it was 0.9, and this is a embryonal rhabdomyosarcoma, very commonly misreported by radiologists only as hemangioma and SEND, because we are not specifically, we don't have that knowledge that this embryonal rhabdomyosarcoma is common in children. And if our ophthalmologist will tell us, then we'll be like, yeah, we know what to do and how to figure that out. So here you need a dynamic contrast and you need a diffusion. Sometimes all the clues will point towards a rhabdomyosarcoma. Like this child had an enlarging lesion for 4 weeks, very bright on T2, deforming the globe, even causing stretch injury of the optic nerve, which is showing diffusion restriction. But the lesion itself is not that dark, and here the ADC value was high. So everything was pointing to a rhabdomyosarcoma except for the value. So in these cases, we forget the value. So don't let one finding change your entire diagnosis. So here it is supportive, not absolute. This is an adult extracorneal mass, very homogeneously enhancing. Now these are T2 slightly low. we've gone from T2 bright to T2 slightly low. Like ma'am had very nicely shown some lymphoma cases. This is also restricting on diffusion. It is sort of encasing the globe, and this is in the extracorneal space, and it is very characteristic of a lymphoma. So this, for us, we call this a dirty gray. Like you have a salmon flesh, we call this dirty gray. When we start seeing this signal intensity, where it's starting to become low, we really think of lymphomas. They can happen intracorneal, extracorneal. This is again a case where you can see the intense diffusion restriction. It's turning dark on the ADC map. Here the ADC value will be close to 0.7. Here you can have another one, extracorneal, going even into the pterygomaxillary fissure and the pterygopalatine fossa, almost like fungus do, but this is showing homogeneous enhancement and restriction. So this is also a lymphoma. Now T2 lesions, when you have inflammation surrounding them, when you have inflammation surrounding them and you have areas of non-enhancement within the T2 lesions, the chances of fungus is much higher. So this is a case of mucormycosis. We can see premaxillary and extracorneal T2 hypointense tissue, all non-enhancing because it's an angioinvasive fungus. So this is typical of mucormycosis. Another case, similar T2 hypointense tissue with surrounding inflammation. We have non-enhancing area here with peripheral restriction. This is a fungal abscess in the intracorneal space. Now, not all fungus acts like this. Aspergillus can go chronic, can go invasive and chronic, has very little reaction around it. So this is premaxillary, infraorbital, foramen and extracorneal, and showing homogeneous enhancement, but restricting like fungus. So this, when we see this combination of something that is really dark, looks like a fungus, we generally have IgG4 pseudotumor and aspergillus. In India, you should not forget aspergillus. So this patient was a renal allograft recipient, and this came out to be aspergillosis. Mucormycosis does not enhance, aspergillus does. This was a bilateral case of lesions involving the lacrimal gland. When it's bilateral, think of systemic. So this was a IgG4 case. It could very well have been Wegener's or sarcoid. You can't really differentiate until you do more tests. So these were a bunch of T2 low lesions. I just want to finish this last case. Very often we find it very difficult to figure out if you have an early orbital apex syndrome versus early fungus. So usually we go by, is the sinus involved? In this, there was some sinusitis. So we did a biopsy. We got nothing. There was no fungus. They treated with steroids. And then 2 months later, it became worse. The amount of enhancement increased. The sinus became worse. They redid a biopsy and they got aspergillus. Despite treatment in February, from December to February, it worsened, involved the cavernous sinus, and thrombosed the ICA. So this is the diffusion restriction as it changes, becoming worse and darker in the apex, becoming worse and darker in the apex and the cavernous sinus before creating an infarct. So we have to be really careful with these. There's nothing that I can say apart from image earlier rather than wait for 2 months if your patient is not responding. Do it earlier to show the change of fungal signal in the orbital apex, because that happens. Just finishing off with an optic nerve glioma, everyone has seen these, but we got this interesting case where you had an atypical looking optic nerve glioma because it had this black thing. So we imaged it further, did a 3D, found a scolex at the anterior end of it, and then gave a medical treatment, and it calcified. Optic nerve became normal. So this was an optic nerve neurocysticercosis. So if you find an atypical finding, aggressively image. Do something new, do something more advanced in terms of sequences. Thank you. Thank you for your kind attention.
Thank you so much, sir. That was really pearl to the existing knowledge. Yes, one important thing that these days diffusion weighted image helps us a lot in differentiating the malignancy or the neoplasm from any other benign lesion, benign condition. So that is very important in our practice. Sir, would you like to add something?
So can you tell me what is the role of MRI in thyroid related orbitopathy? Thyroid related orbitopathy.
Right. So it's very so thyroid ophthalmopathy is very clearly visible in terms of enlargement of the extraocular muscles. It has a very specific pattern. Starts usually with the inferior or medial, and then goes to the superior. Right. So usually starts as unilateral. I mean, we see lots of cases where they're bilateral. In some cases, it might be unilateral also. But if you have this pattern of enlargement where it's starting with the inferior and medial, chances are higher. Retroorbital fat increases. Even intramuscular, you can see areas of fat deposition on the MR. I'd like to say definitely one case that we saw which was very interesting was bilateral only levator palpebris superioris involvement. That is a atypical pattern, but it is the most common atypical pattern apart from the normal. So if you see a patient with bilateral LPS enlargement, that is also thyroid ophthalmopathy.
And one small, I think, madam.
Yes, yes.
So in thyroid eye disease, the muscles will be enlarged and the tendon will be spared. And basically, as you're a radiologist.
Yes,
right?
ma'am.
So as ophthalmologist, what we see in MRI is for activity. So we always take an MRI to see only if there is an active disease, because the treatment depends on the activity. If there is an inactive disease, it doesn't warrant any treatment as a physician is concerned. If there is an active disease, then we go ahead with either steroids or immunosuppressants. Now there are so many biomolecules which have come up with which we treat thyroid eye disease. So T2 weighted in T2 weighted images, if it is hyper intense, if the muscles are bulky, thyroid eye disease mainly the pathogenesis is it imbibes water, there is fat proliferation. So anything which has water is white in T2. So in T2, if the muscles are white, hyper intense, then it means the disease is active, and it is taken at the mid level. We see at the mid level. That's one name.
Thank you, sir. And one more question, that we had a little bit confusion, like, and I know that when the mucormycosis was so much popular, that I think we thought that ENT people are the first person to do FES, and still there are a lot of controversies, so many, like like a diagnostic and a clinical appearance of mucormycosis. Can you tell me, the highlighting the point, which is the earliest sign for a mucormycosis is to be detected? By MRI.
By MRI?
Yeah.
So we had around 200 patients at our hospital.
Okay.
Because Gangaram was a referral for mucor in Delhi. So the earliest sign that you can find is actually in the nasal cavity.
Okay.
So what happens is that the turbinate that it involves, because it is angioinvasive, it stops supply to that enhancement of that turbinate. So that turbinate turns black on the post-contrast study. So that's called a black turbinate sign. It's one of the earlier signs.
Okay.
In all of our imaging, we actually found that diffusion restriction and non-enhancement in soft tissues anywhere, whether it is in the turbinate, it is in the tissue near the medial canthus, or if it is even in a sinus, it is more likely to be mucor. Ophthalmic artery invasion is one of the earliest signs. I've seen it happen with as little as one air cell involved in the ethmoid. So that pattern of spread, where it is looking like it is going along vessels, is the hallmark, and it sometimes creates infarcts in soft tissues distal to that. That is also a hallmark of mucor only.
Right.